Hey everybody, it's Adam Farkas from ODWire. Welcome to another ODWire webinar. And tonight, sitting to my left, I have with me Paul Farkas.
Hi,
And
great being here.
Paul, it's unusual to have you here, but thank you for coming again
on a rainy
on
night.
a rainy night. And thank you all for showing up here tonight as well. So tonight we're going to talk all about mastering Alcon's simplified multifocal contact lens fitting process. And this is actually sort of the last webinar that we're doing on a series on multifocal lenses. And
Right.
I know, Paul, one of the things that we talked about a lot is following the fitting guide, right? We said it over and over again in the series, following the fitting guide. And tonight's going to be kind of a cool one because we're going to show people in reality how to do that. We're going to have some really interesting cases and show people how it all works.
Great, terrific.
So it sounds like a good plan. So before we get started though and introduce our speaker, let me just remind everyone, on the right side of your screen, you'll see a box that says questions. As the show goes on, feel free to type questions in there and we'll hold them aside. And at the very end, I'll verbally ask our speaker the questions. Make sense? All right, so with that said, let me plow on ahead here. So our speaker tonight is Dr. Milana Matz of North Suburban Vision Consultants in Deerfield, Illinois. And I can't think of a better person to talk to us about this particular topic. Milana graduated with honors from the Illinois Eye Institute and the Illinois College of Optometry. And she actually did her internship where she's working right now at North Suburban Vision Consultants, and then stayed on.
She was a talent.
She was a talent. So Dr. Barry Iden, of course, runs the practice. So she stayed in and she's working there, and her emphasis is on contact lens specialty care. So she's the perfect person to talk to us tonight about this multifocal fitting process because it's integral to what she does in her practice. So Milana, thanks so much for being here tonight.
Thank you, Adam and Paul, for having me, and thank you for this wonderful introduction. It's such a pleasure. I'm very excited to partake this evening and to kind of get everybody comfortable and excited about fitting multifocal lenses, and of course, getting a little bit more comfortable about the process. So without further ado, if it's okay with you, we'll go ahead and get started. And again, please feel free to express any questions. We'll try to address everything towards the end. We'll go ahead and start with mastering Alcon's simplified multifocal contact lens fitting process. Before we start, I do have to let you know that I am compensated by Alcon to do this webinar this evening, but it really truly is my pleasure to do so. So without further ado, here we go. The key to successfully fitting an Alcon multifocal contact lens is to follow the newest Alcon multifocal fit guide, which walks through a simple two-step fitting process. And by following the fit guide, 80% fit success is expected with one lens per eye, and 96% fit success is expected with two lenses or fewer per eye. To you, as an eye care professional, that means minimal chair time and maximum success. All three multifocal lens options in the Alcon multifocal portfolio follow the exact same fitting steps because all three have the same innovative multifocal design. All Alcon multifocal lenses have what's called the precision profile design with low, medium, and high add powers in the center. This design allows for smooth power progression from near to intermediate to distance. To have a smooth power profile and to minimize aberrations, continued minus power is added in the periphery of the lens. This extra minus may result in a plus power over refraction at distance. The idea of the precision profile design is to allow our patients clear binocular vision at all distances. The low add lens is designed with small amounts of add of up to a diopter and a quarter to ensure minimal degradation of distance vision in emerging presbyopes. And the three add options, along with a precision profile design, work as a unique system to facilitate transitions as symptoms of presbyopia become more of a challenge to our patient. The amount of add power differs centrally, but the power profile is kept the same in the periphery. The first step of the fitting process is to determine the initial lens using a new SpecRx. So new SpecRx doesn't mean a prescription we gave to the patient a year ago, doesn't mean a prescription they're coming in with from a different provider, doesn't mean a prescription that they're bringing in from another family member. Make sure that you spend a little bit of time and get a new SpecRx for your patient. The initial contact lens power should be determined using a vertex converted most plus, and do not be shy here with the plus, spherical equivalent distance prescription and adding a quarter diopter to each eye at distance. Lens add is based on the lowest accepted add. This is really important, so I'm going to repeat myself. Lowest accepted add, usually lower than the age expected norm and lower than the add that you would typically prescribe for that same patient in their progressive lenses for their glasses. Based on the lowest accepted add, you would then select a low, medium, or high add, and you can see the power breakdown in the add selection table that we have here on the slide, and is also found in the fit guide. Note, same add powers in this is selected for both eyes, and any type of eye dominance in this particular case when fitting a multifocal lens is completely disregarded. Once the initial contact lens is selected, the lenses are inserted and the patient should be allowed to adapt to the lenses outside of the exam lane and in a real world setting, typically for about 5 to 10 minutes. Once the lenses are on the eye and before you send the patient out into the real world setting, be it your optical or the waiting room or the likes, encourage the patient's success by suggesting some appropriate lens adaptation points. For instance, take a few minutes to look at your phone. See how the lenses work while you explore a selection of glasses or while you're looking at the computer. Feel free to step outside for a brief walk and see how the lenses work outside. So now that the patient has been out for about 5 to 10 minutes and has had a chance to adapt to their lenses, it's time to move on to step 2 of the fitting process. Performing the distance over refraction is easy, but there are some key points which must be followed. With both eyes open, we're going to use loose lenses or lens flippers to perform a distance over refraction over one eye at a time. You're going to add plus power and quarter diopter steps until the patient reports blur at distance. You may find that the patient accepts a significant amount of plus at this step. This is because there's a significant amount of minus in lens periphery. Remember the precision profile design we briefly spoke of prior. If you find, however, that the patient is accepting over 3/4 to 1 diopter in each eye, you may want to consider removing the lenses and reconfirming your initial refraction. Once you've established the over refraction in one eye, then you want to go ahead and repeat the same process over the other eye. And then verify your results binocularly by having the patient look at a distance and a near object through the loose lenses or through the flippers that you're presenting. If the patient accepted plus over one or both eyes, make that change only to the distance power. We're not touching the add here. You're going to keep the add the same as it was. You're going to insert new lenses, and if the vision is functional, then the diagnostic lenses should be dispensed for about 5 to 7 days, and of course, schedule a follow-up with your patient. Help patients understand what to expect from their multifocal lenses and how to assess their vision. You want to set realistic expectations and emphasize that 80% of visual tasks should be addressed with the appropriate use of lenses. Vision is likely to improve gradually over time as the eyes and the brain adapt to this new visual system. Ask the patient to keep track of their visual performance and communicate this information to you at your follow-up visit. Adjustments to the contact lens power may be indicated at the follow-up and is normal. It's to be expected. In addition to reviewing these points with your patient, provide them with the Alcon patient expectations tear-off sheet to offer support when you're not there to answer some of their questions when the patient's headed home. It's also critical to provide tips that will help patients during the initial period. For near vision or in dimly lit settings, suggest additional lighting or ask your patient to modify their working distance. Sometimes pushing the object of interest closer or further may help them out. Stress the use of both eyes together for all visual tasks. And I always tell my patients, do not cover one eye to see the performance and compare it to the other eye. We don't function normally this way. Both eyes are always open. Encourage use of lenses in their day-to-day setting. And also very, very, very important is to educate your patient on the need of non-prescription polarized sunglasses to maximize visual outcomes on bright sunny days. I always stress this to the patient to maximize the visual potential of their eyes. They must have the necessary tools, such as sunglasses being one of them. And I usually like to relate this to sports because most patients can understand this. And I say, you can't play hockey with just the puck. You need to have the stick too, right? So be creative, try to relate to your patients. But this will, of course, create the opportunity to boost optical revenue for you and is a win-win for you and your patient. Treat the follow-up visit as another opportunity to assess how the patient's needs are being met and provide additional tips for success. Consider the following questions and talking points. In what settings or activities have you been most satisfied with your multifocal contact lenses? When are you least satisfied with your vision? During your adaptation period, you should have noticed and may continue to notice improvement in performance of your multifocal contact lenses. Have you noticed any changes? Anything you're unhappy or uncomfortable with? Keep in mind that making adjustments is very normal at this stage. Have you found it beneficial to use additional light and dim settings? This is absolutely normal, and actually I recommend it. Also, I want to remind you that you should be wearing sunglasses when you're out during the day. Asking these types of specific questions can help identify potential challenges and provide an opportunity to make modifications to the lenses, as well as provide additional recommendations to help ensure successful wear. So now let's go ahead and go through a brief case study, which shows us how following Alcon's multifocal contact lens fitting guide simplifies the fitting process. In this example, we have a 45-year-old patient with a busy work life and a family life who has started to experience blur vision at near. In addition, she frequently works at the computer, prioritizes her appearance, and let's say she's not really all that excited about the idea of having to wear glasses, which all make her a really good candidate for multifocal contact lenses. So, an eye exam for this patient gives us a vertex-converted MOST plus spherical equivalent distance correction of right eye plus half a diopter with 1 diopter of add, and left eye plus 3/4 diopter with 1 diopter of add. Based on this information, what are the correct initial lenses for this patient? Now, remember the 3 most important things we've learned so far about a successful fit. 1, follow the fit guide. 2, follow the fit guide. And 3, remember to follow the fit guide. So as we look through some of these options, remember what our steps are. We want to go ahead and add a 1/4 diopter to the distance power here. We're going to add plus a 1/4 to the 50 diopter distance correction. So our right lens power is going to be a plus 0.75. And remember, our lowest acceptable add was a plus 1. Thus, low is going to be our selected add for the right eye. For the left eye, we started off with plus 0.75. We're going to add a 1/4 plus to the distance power, resulting in a plus 1. And again, keeping the adds the same, this patient is going to stay in a low add for the left eye as well. So that's choice A, plus 0.75 for the right eye, low, plus 1.0 for the left eye, low as well. Next, once the correct initial lens is selected and the patient has adapted to the lenses for about 5 to 10 minutes in the real life setting, the next step with both eyes open is to use our handheld lenses to perform a distance over refraction on each eye individually, adding plus power and 1/4 diopter steps until the patient reports a blur at distance. So we're going to begin with the right eye. We're adding a 1/4 in front of the right eye, and the patient reports that it causes distance blur. Based on this particular response, what do you think is the correct next step? Well, if you remember for our fit guide, if the patient does not accept any plus over the distance power in that eye, we stop the over refraction and move over to the next eye. So the correct answer here is going to be B, leave the power unchanged, and the final power for that right eye stays as a 0.75 low. Next, we move on to performing the distance over refraction in the left eye. Again, with both eyes open, we're using our handheld lenses to perform the distance over refraction, and we're introducing a +1/4 to the left eye, and the patient is going to tell us that there's no decline in the distance vision. So with that being said, what do we do next? And remember again, for our FID guide, if the patient is accepting that 1/4+ over one eye and tells you either their vision improves or remains the same, we're going to keep introducing more plus power. So the answer here is D. We're going to add another 1/4 step on that eye, 1/4 diopter of plus with our handheld lenses. As per the fitting guide, we're now going to add a 1/4 diopter step to the left eye, and in this case, adding that 1/4 step, the patient is reporting that she's seeing blurry at distance with both eyes open. And now, based on this result, what do we do next? Well, in this case, since the patient no longer accepts any more plus, we're going to increase her power by just 1/4, and the final power for the left eye is going to be 1 1/4 low add plus 1 1/4 low add. So now you fit your patient, and your final prescription for that patient was a 0.75 low and a plus 1 1/4 low. And this is the final prescription for that patient. The next step is to dispense the lenses to the patient and schedule a follow-up appointment in about a week. The Alcon multifocal fit guide must be followed every time you fit a multifocal contact lens. Let's quickly review the steps here in the fitting process to help us remember what it is that we need to do to fit a lens. Determine the initial contact lens power using a vertex converted most plus spherical equivalent distance prescription, and then add 1/4 plus to each eye. We're going to then select a contact lens add using the lowest acceptable spectacle add. And remember, as a reminder, this is really important, and this is where a lot of mistakes happen. Do take the time to figure out what is the lowest acceptable add that the patient will take. A lot of times, and I mentioned this before, this power is going to be less than their age-expected norm, and it's going to be less than the power that you're going to be prescribing in a progressive lens for their eyeglasses. Give the patients time to adapt to the lenses in the real-world setting. For the distance over refraction, we're going to go ahead and add 1/4 diopter steps of plus over one eye at a time while keeping both eyes open until there is a reported decline in distance vision or a blur at distance. By doing so, Alcon data shows an 80% fit success rate with just one lens per eye and a 96% fit success rate with two lenses per eye, where the simple multifocal fitting process is followed. So one thing that we really have to follow is the fit guide. Everything is spelled out. All the steps are there. The table with the adds is there for you to easily select the add power that's appropriate for your individual patient. And remember, please use the new fit guide. Any old fit guide that you may have, which has different add powers for the two eyes, is no longer applicable. The new fit guide should be followed for you to be successful. Thank you, and let's go ahead and cover some questions that you may have.
Excellent. Well,
Okay.
thank you so much, Milana. That was great, great overview, and hopefully people see how easy it is to follow this fit guide, right? So people just don't go off and do their own thing. So I guess, just a few questions coming in, and they're just starting to roll in again. If you have any questions in the question box on the right side of the screen, feel free to type them in. Question number one, let's see. Oh, interesting question. Is the lowest acceptable add determined in the glasses prescription?
Yes, so this is a great question. Typically, the lowest acceptable add is going to be performed when you're doing the patient's refraction. So usually I'll go ahead and perform their distance refraction, and then I will drop in the near add card, and I will start to click plus 1/4 at a time until the patient reports to me that they can just make out the 20/20 line on the reading card. I usually will then give them just one more click of plus, and that is my lowest acceptable add. Remember, I will then continue to add more plus vernier to determine what their glasses prescription is going to be, what their progressive lenses are going to be, but that is not the add that I would use for the initial contact lens power.
Right.
Okay, I'll come up with a real world problem.
Uh-oh, okay.
There we go. A good portion of the people that you will have in your market are monovision patients. And
sure.
And some of these monovision patients will start having binocular problems as you start moving up in their ad. Let's assume you have someone that's monovision, where their reading correction is up to 250, plus 250. Would you then but they don't do a lot of reading, but they're on the computer a lot. Would you correct them for their computer ad, or would you correct them for their higher reading ad?
Well, and that's a very interesting point, because we deal with these patients quite a bit. You know, by having the design that we have, the precision profile design not only addresses the reading portion, but because of the progression of power in that lens, we address the intermediate vision as well. So when I am refitting a monovision patient into a multifocal lens, I use the same exact approach as I would with a patient who wasn't in a monovision lens. I will refract them to get their distance correction, and then again aim to get their lowest accepted ad. And interesting enough, as you mentioned, this particular patient who is wearing monovision, taking a 250 ad, a lot of times will actually have a much lower lowest acceptable ad, and will do very, very well in a contact lens, in a multifocal contact lens, with an ad that's not necessarily a high.
Right. Okay. Good answer.
Good answer. And you know, funny, we have comments as well as questions coming in. One of them was, just wait until you get a really picky patient. And this sounds actually a lot like Paul and your experience back in the olden days, before the process was much more cut and dry as it is now.
There was a lot of trial and error in the old days.
Yeah, and you know, picky patients they're there for a reason, right? There's room for everybody. And honestly, I really do enjoy having a picky patient, because I enjoy proving them wrong to some degree. Not everything is for everyone, and we have to realize that, right? Not every lens out there is meant for 100% of your patient base. However, there are a lot of patients out there who are not offered a multifocal lens and really could benefit from it. So setting realistic expectations before we begin a contact lens fit, and specifically a multifocal contact lens fit, is really very important. And so a lot of times before I begin even putting a lens on a patient's eyes, a multifocal lens, I will ask the patient, if I am to give you 80% of your day in a multifocal contact lens, would that be something that you would be happy or satisfied with? And if the patient says yes, that to me, that's a good candidate. And if a patient says no, which, you know, some do, then maybe that's not the best candidate for a multifocal lens. So we have to be realistic with what to expect.
Absolutely.
Yeah.
A couple questions actually just came in at the same time. How much SIL can you try to work with before you can determine whether or not it's going to work?
And I love this question. So the wonderful thing about this particular design is I will typically accept at least a diopter and a quarter of SIL before hesitating fitting the lens. So if I do a refraction and I see that a patient has 3/4 of a diopter, up to a diopter and a quarter, I will not shy away from fitting one of the multifocal lenses. I've heard some of my colleagues go up to a diopter 75, and I think that that's something that can be successful with the right patient, and you really have to screen your patients and realize what their expectations are and set them up for realistic expectations. But in my practice, a diopter and a quarter or less is something that's very doable.
Right. Question here, and actually even this one I can answer, because the question was, will an early presbyope, say 40 years old, still be a good candidate for the low ad? And I can say, at least with a sample size of 1, the answer is yes.
100%. 100%. Yes.
Yep.
Yes. This is a wonderful question. I'm happy that it came up, because one of the things that I like to hit on is I will tell you that I'm no longer waiting for my patients to hit age 40 to 45 to start introducing a multifocal lens. In today's day and age, and us being on devices and on computers and we're using our eyes for near so much, I'm finding that presbyopia is emerging a whole lot sooner than we used to see. So a lot of times I'm now introducing presbyopia, or at least the concept of presbyopia, to patients in their mid-30s or late 30s if they're not expressing symptoms yet, for them to be aware, so that as I continue to manage these patients, they're coming in and knowing that there is something that we can do in contact lenses to address both their distance and your symptoms.
Right. Question here, your approach to hyperopes, any different, or do you just follow the fit guide the same way?
You know, I do three things when it comes to my hyperopes. I follow the fit guide, I follow the fit guide, and I follow the fit guide. Really, it's all the same. It's, you know, the prescription is one, and we know that, but a lot of times the success really comes from following the fit guide and having realistic expectations, setting realistic expectations with your patients, and really doing a nice job screening the patients who are and are not good candidates for these types of lenses.
Right. Question, you use the fit guide for all three of the different brands in the Alcon family. The question is, does it all work about the same in terms of the success rate using the fit guide?
Yes, 100%. Because the design amongst the three different multifocal lenses, the Dailies Aqua Comfort Plus multifocal, the DT1 multifocal, and the Air Optics with Hydroglide multifocal are all fit exactly the same, following one fit guide, which is so unique and great because you have options to offer your patient based on their specific needs, and you don't have to learn three different types of fit guides.
Right. A comment here, I guess not even a question. I have more problems with myopes than hyperopes. Do you have a similar experience?
I have not established that. Typically, the one thing that I find a lot of practitioners have trouble with is shying away from giving the patient enough plus in the distance. And I think sometimes that's kind of where we hit a little bit of a wall, is when we refract the patient, we like to give them a good amount of minus, which works well when we're prescribing them eyeglasses to use. But when we're talking about a multifocal contact lens, really push as much plus as you can at distance, and don't push too much at it near. Because remember, using the lowest acceptable add is really going to help with essentially preserving that distance vision.
Right. And in fact, I'll make a little comment here. I'm a hyperope, and what's interesting, and I guess it's because of the design of the lens, right, where they have minus at the periphery. We've had to push a ton of plus to get my prescription accurate, and I guess that's pretty common.
It's very, very common. As we move from center to the periphery of the lens, that progression is very unique, and we do find that there's a lot of minus out in the periphery, and sometimes practitioners get a little bit nervous as we start over refracting each eye at a time, and we're finding that we can give the patient an extra half a diopter, maybe 3/4 of a diopter plus, and their vision stays the same or improves at distance. And the reason that we can do this is because of the design and the amount of minus power that's out in the periphery. Now, I also mentioned before, you know, if we start finding that the patient is accepting a lot of plus, you know, we're going beyond a diopter, at this point you may want to raise a little bit of an eyebrow and maybe reconfirm your refraction, because you know, as much as we can push plus, taking a whole lot probably means that there's something that needs to be double checked and reconfirmed.
Right. Okay. Well, it looks like we're just running out of time here. I was just wondering if you had any sort of parting thoughts for us.
Well, really, the biggest thing is, you know, don't be shy. This is a wonderful option for patients. And a lot of times we avoid fitting multifocal lenses because it's scary, or because we have limited success rates, or just, you know, because we feel that it takes too much chair time. And all you really have to do is just get acquainted and familiar with the fit guide. It's there at your fingertips. I encourage you to just go ahead and start fitting those patients, and you will be very, very pleasantly surprised as to how easy it is and how much you impact your patients in a positive way.
Excellent. Well, thank you so much for this, Milana. And by the way, if there's any other questions that people have, I will be posting the additional questions up on ODWire,
Right.
and we can continue the conversation there.
Thank you very much.
All right. Have a great night, everyone.
Good night.
Bye-bye.